So we asked the question, why do you do it? And it's not just van drivers, it's helicopter pilots as well. You can ask the question, what's happened here to this helicopter? And, you know, the helicopter drivers are very skilled people, they are very intelligent people. This guy was a very experienced pilot. And what's happened here is he's started his helicopter up too close to the hangar door. But the question is, why? Why did this experienced, skilled pilot make this near fatal error? And I deliberately used an example from the airline industry, because in the airline industry, there was a landmark incident. And it was back in 1978. And it was the most catastrophic airline accident to date. And two aeroplanes collided on the runway. So you can see there the blue aeroplane, and you can see the red aeroplane. And the red aeroplane went to the end of the runway and was told to hold before takeoff. And the blue aeroplane was told to turn off at junction C3. But it missed C3 and it went to turn off at C4. And the red aeroplane started its takeoff run before it had permission to take off. And it was foggy, and so both the planes collided on the runway, which resulted in almost 600 people dying. And this is still the worst airline accident to date. But what's interesting about this accident is that they knew there was absolutely nothing wrong with the airplanes at all. The whole accident was caused by human factors. So they started to ask the question, what was it that allowed two airplanes to be on the runway in the fog? Why did the blue aeroplane, the KLM aeroplane, take off before it had permission? Why did the Pan Am aeroplane miss its junction? And they came down to it that it was all to do with human factors. And so they started to look at human factors in aviation. And when they started to look at airline accidents, they realized that 80% of airline accidents are down to human error. And since then, there's been lots and lots of research in medicine and dentistry, and they realized that 80% of our errors are down to us, are down to human error, not technical ability or inadequate knowledge, down to human error. And I see it all the time in my clinics and in my referrals. I can give you hundreds of examples. You can ask the question, what happened here? Well, this was a very experienced oral surgeon that was trying to do a connective tissue graft. But he designed his incisions in such a way that he's cut the blood supply off to this flap, and you can see the necrotic flap there on the left-hand side. And you can see the blood supply here that he's cut through. And so the question is, why is this very experienced, very lovely guy, he can't do more for his patients, cause harm to this one patient? And this is a particularly challenging case for me, because how do I fix it? If I did a free gingival graft or something like that, where would the blood supply come from? In actual fact, what I did is I took some PRF, I used some PRF membranes to repair the defect, and the patient was fine. This is an implant placing dentist that's done hundreds and hundreds of implants. And then he phoned me up and he said, look what I've done. I put the implant into the back of this tooth. And it begs the question, why is this dentist who's done hundreds of implants on that morning in that patient caused harm in this case? And it's funny, when we start to analyze these complications, we put a lot of emphasis on the technical and the biological aspects. You know, this tooth's tilted, maybe that's the reason. We don't tend to look at the attitude of the practitioner, the environment, and the behaviors of the operating team. I can show you slide after slide after slide. This was a consultant maxillofacial surgeon that put implants in, and he's put them in such an aberrant position that their lab couldn't restore them. So we sent to our technicians who were able to. In fact, my technician asked me if he was trying to restore it with a nose or with teeth that are that badly positioned. But what made a very, very qualified clinician put implants in such a position they could hardly be restored? Well, I can argue with you that it's human factors. And there's lots and lots of evidence that if you start to introduce the science of human factors into our practice, we can start to reduce some of these errors. This paper here looked at almost 182,500 medical procedures, and they divided the operating teams into two: those that had training in human factors and those that didn't have training in human factors. And those that had training in human factors had 50% mortality and 50% less complications than those that had no training. This paper here, commissioned by the GMC, looked into prescriptions. 1 in 10 junior doctors had major errors on their prescriptions and 1 in 20 consultants. A review by the World Health Organization looked at its member groups, and an average year, there's 2,700 patients harmed by wrong site surgery. So this isn't complications because of blood loss or infection. This is you chopped the wrong leg off, you took the wrong eye out, you took the wrong kidney out, took the wrong tooth out. But perhaps the most convincing argument for the introduction of human factors is in anesthesiology, because this paper in 2014 looked at how safe is it to have a general anesthetic in 1970 and how safe is it in 2014. And it's quite a risky thing to do in 1970. You know, you might as well go and do a bungee jump or climb the Himalayas. Yet in 2014, it was almost in the ultra safe zone. And what this paper did is it looked at the differences in anesthesiology between those two dates. And it found, yeah, for sure, there was some difference in the gases and there was some computerization of the infusion pumps, but almost all the innovations were to do with human factors. Things like you can't connect the wrong hoses together, things like team briefings, things like color coding, working hours restrictions, checklists. And they concluded that in actual fact, human factors interventions is a major reason why anesthesiology is as safe as it is today. Interestingly, when I was looking, when I was researching this, I came across this report that anonymously asked how many anaesthetists admitted making a fatal error. So this means that the patient has died because of their mistake. And when they're asked anonymously, almost a quarter of anaesthetists have admitted killing somebody because of their medical error. A staggering statistic. And all the research in anesthesiology says that human error is the most highest contributing factor to mishaps. And there's more and more evidence now in the literature emerging that human factors are inextricably linked to patient safety. Last year, 98,000 people died in America because of medical error. Medical error is the 5th most common cause of death. Did you know that? So what about dentistry? Well, there's lots of papers reinforcing human factors in dentistry. So this study looked at 11,000 implant operations, and they standardized these operations. So they use the same kit, the same protocols, and it's the same patient base. And there's 23 surgeons, but all these surgeons had very different outcomes. And the question is, how can, when you standardize all this protocol, how can they have different outcomes? And they concluded it was all down to the surgeon. And those surgeons that could deal with stress best had the best clinical outcomes. Interestingly, women came out much, much better than men in that study. In a literature review that I did, I looked at root causes of errors, and I found actually it's much more than 80%, it's more like 95, 96% of our errors are down to human factors. And when you look at our awareness of this, one of the things I wanted to do is I wanted to introduce some teaching apps into our teaching clinics. But I wanted to make sure, first of all, that having a smartphone on the clinic wouldn't be a distraction. So I did a small study looking at how many dentists thought that their phone had distracted them from their clinical duties. And almost 62% of dentists said, yes, my phone has distracted me from clinical duties. But despite that, despite knowing that, almost 90% of these dentists still had their phone on them. They're just clearly unaware of the implications that could possibly have. Jack Roberts and I did a small study looking at prescriptions. We looked at over 200 prescriptions, and 60%, 66%, 2/3 failed to meet legal and ethical guidelines. How can you expect to have good quality restorations that fit well when 2/3 of the prescriptions don't have the basic requirements on them? I converted the Who Safe Surgery checklist for dentistry, and I insist this is used in our teaching hospital because it's a known barrier to wrong tooth extraction. And despite the fact that all of our students know that human factors is my thing, all the staff ensure the governance protocols and that this is used. And despite the fact they won't pass the course unless they use it, they still just saw it as an additional burden. They skipped items. They allowed interruptions. They just did not see the need really to use this very, very important tool. And that was shocking enough for me. But what really shocked me was this study that I did. I did this a number of years ago. I trained 200 dentists in human factors. And they had to go on a training day, and they had breakout groups, and they had things very clearly defined. And then we asked them how many errors they make a day. And they came back to me, on average, they made 2 to 4 errors per day, 1.4% of them leading to an adverse event. An adverse event was defined as the patient was actually harmed. And the reason why I thought this was quite shocking is how many dentists on the register? 45,000 dentists, all making 2 to 4 errors per day. So what's that? It's 150,000 errors per day being made in dentistry. These are huge numbers. And that's just dentists. When you add in nurses and hygienists and technicians, you wonder why we're so safe as a profession as we are. And the reason why it worries me is because of this ratio. It's called the Heinrich ratio. And he was a naval officer. And he looked at safety in yachting and in the Navy back in the 1930s. And he said for every 600 sort of near misses, there's one fatal accident. Now, I'm sure the ratio isn't quite the same for dentistry, but it wouldn't be that dissimilar. And so if there are 600 near misses and one of them is a fatal accident, or 10 is a patient is severely harmed, I don't want you, or I don't want me or my team to be that one person. And so the idea of human factors is if we can really reduce these near misses and these unsafe acts, then we can totally eradicate these non-fatal accidents and these fatal accidents. And I can give you some figures because the hospitals are obliged to release these figures. So if you just look at the Wirral Community Trust and Arrow Park Hospital, you can see these figures are per month due to error. So you look at the second column there, 5 people died that month because of error in the Foundation Trust. 2 people died that same month in the teaching hospital. If 5 people died on a helicopter, it'd be all over the news, but these people are dying every month in a hospital and no one has really even mentioned it. It's just accepted as part of medicine. And the only real way that we can address this is by introducing human factors and the science of human factors into our practice. So what do I mean by human factors? So here's the definition of human factors, which essentially is understanding how the design of the workspace, task factors, communication, culture, and social aspects, and this type of thing affects our behavior and our working life. But it's all a bit clumsy, isn't it? I simplify it very much in my head. And I see human factors as a difference between competence and performance. So competence really is knowledge and performance is ability. So I'll try and give an example. All of us, thanks to Robbie's fantastic lecture on oral surgery, can competently take out an upper molar tooth. No problems. Given enough time, the right equipment, it's no bother at all. However, you go into work tomorrow morning and because of the traffic, you're late, and the patients are anxious because of COVID, and your nurse is isolating, and the aspirator doesn't work. And already when you started the procedure, the receptionist is coming asking when the next patient is to be seen. All of a sudden, your stress levels are increasing and the ability for you to deploy your excellent skills is decreasing. And so your performance, your ability to perform is likely to cause you to make an error. We see it a lot in restaurants, don't we? Waiters are amazing people. They run around everywhere. They're being asked to get drinks from the bar and food and bills and everything else. It's a wonder they don't make many errors. And in all likelihood, they do. The good thing about a waiter, though, of course, is the consequence of their errors is that your food is cold or they forget your drinks. I came across this nice example on the internet. This is at a restaurant called Hawksmoor. In fact, I liked the story so much, I went and visited it a few months before lockdown. And they've got some very rare and some very good wines. And this particular table ordered a bottle of wine that was worth £260. But next to it on the shelf was a bottle of Lapin Pomerol 2001, which was worth £4,500. And the waiter picked up the wrong one and gave it to the table. Only realized, of course, after it had been drunk. And what I thought was really, really nice about this story is that this is the Twitter that the restaurant put on the internet afterwards to the customer who accidentally got given the bottle of wine that was worth $4,500. We hope you enjoyed your evening. But to the staff member who accidentally gave it away, never mind, one-off mistakes happen. So they realized actually it wasn't the waiter's fault, he was just doing the best that he could have. And if they sacked the waiter, and that's the response I normally get when I put this into presentations, the response of the audience is usually, just sack the waiter. But if you just sack the waiter, the next night, exactly the same thing can happen. You need to change the system to prevent the error. And we're lucky in dentistry because although that we might have many errors, most of them don't lead to complications. And we do have these barriers up, which stop them. I'm sure you will recognize this. This is Reason's model. It's been superseded by a few different ones now, which are much more complex. But this really does nicely illustrate we want to have as many barriers as possible to the progression of an error. And that's what human factors is about. It's not about having just one impervious barrier. It's about having hundreds and hundreds of barriers to stop an error being made. In fact, every single member of your team should be a walking, talking barrier to the prevention of errors. And the reason why is because although most errors don't lead to complications, what they do is they reduce your safety margins. So if you're walking along this plateau here and you fall over on the left, you just get up and brush yourself down and away you go. If you walk along this steep precipice on the right and you fall over, you're probably going to die. And where we want you practicing is on the left. You'd be surprised at how many practitioners are walking along this precipice. And those are the people where those 600 near misses are going to lead to a fatality or a serious injury. And it does happen. If you look at this case here, and human factors is hugely important in operating theatre. But even so, this one slipped through the net. This British man in Australia went in for a cystoscopy, and he got confused and accidentally was circumcised. And why I thought this was on my mind was because when I looked at, he got $35,000 compensation, and my first thing that went through my head was I was trying to work out whether it was worth it or not. I'll leave that for you to decide. So so I've said that human factors is the biggest single thing that we can do to improve patient safety. We can, in theory, reduce our complications and our errors by 80% by introducing human factors. So what are we doing as a profession, as a medical profession, as a dental profession? Well, the medical profession have really taken the lead on this, and they're a long way ahead of us as dentists. And it all started with Professor Buick's report in 2014. And of course, it was really highlighted by the tragic case of Jack Adcock and Dr. Bauer-Garber. And sorry, I can hear somebody else's computer. That's better. And now there's even commissioning in medicine based around human factors. And in dentistry, the only thing we really have is this National Advisory Board for Human Factors, which I set up about a year ago. I was asked to set it up by the GDC. And on this board, there's a CQC, there's a GDC, there's the Royal Colleges, and it's all about how can we improve patient safety by introducing human factors into our regulation. I'll talk to you a little bit about that later on. But even the regulators of the regulators, the PSA, is talking about human factors, talking about the principles of proportionate, consistent, transparent, accountable, and agile regulation. And they've set out the stepping stones for the GDC to follow in terms of creating a just culture and ensuring that they create an environment where we can all learn from our errors. But still, the human factors in dentistry is still very much centered around never events. And what a never event is it's an incident which is entirely preventable. It has actually happened. It does cause harm to the patient, and it is clearly defined. And they differ in the devolved nations, but in England, it's wrong site surgery, wrong implants or prosthesis, and a retained foreign body. And it's so important because these should be never events. I don't really like the name never events because they're not never events by definition. And in Scotland, my colleagues are working in human factors up there, Irene and Paul Bowie, they think we should have a much, much bigger never events list. And they think that all of these things should be on the never events list in the UK. And I do see them all the time, so they're definitely not never events. I see wrong site surgery an awful lot in the litigation that I do. I mean, look at this case here. You can see the picture on the upper right. That's an implant that's supposed to be connected to her prosthesis. I mean, how can I defend this dentist? The implant is clearly in totally the wrong place. And the fact it doesn't really seem to be in the bone. So how can I defend this? Again, this implant is far too buccal. How can I defend this dentist? This patient, these implants are put in far too buccal. You can see them through the mucosa. And she was due to get married. She actually cancelled her wedding because she was in so much discomfort with these implants. They had to remove and augment the site and then replace the implants. So it's something we see all the time. But what is lucky is the British Association of Maxillofacial Surgeons have developed these things called NatSips and LockSips. And these are things that we should all be using. These are taken on board by NHS England and by the CQC, and they're a set of protocols that we should all be using before we do any invasive procedures, including tooth extractions. And they basically revolve around two people checking that it's the right and correct tooth, confirming it verbally, and making sure there's no interruptions that could cause you to make the error. And the reason why it's so important is that if you do make a never event, you are contracted, you're obliged to report it to the CQC. We have no choice, we have to do it. But despite the fact that we have no choice and we're contracted to report these never events to the CQC, how many people do you think do? Well, absolutely none. In a study by Tara Renton, 3 practices reported never events, either to the National Reporting and Learning Service or to the CQC between 2005 and 2014. There's 10,300 practices in the UK, and only 3 people reported any incidents. In this study here, a third of trusts in their study time period had no adverse events. I mean, that can't be true. Prior, one of my colleagues, she did a research project around never events, and she wanted to look at how aware are dentists of never events and the importance of never events. And she had lots of stakeholders. She had my committee, she had the GDC, the CQC, all involved in this research project. And she found that 55% of dentists didn't even know what a never event was, and the same amount therefore couldn't implement these national standards for invasive procedures, or indeed the local ones. And of those that did know, half of them didn't know how to report it, even if they could. And interestingly, when you start to look at the culture around this, 33% said even if they could, they wouldn't. And the main reason of that was because of fear of repercussions or being sued. And dentists just don't report things. And we've learned that through many different avenues. One of my good friends, Lisa Howes, who's just the retired Deputy Chief Dental Officer for Wales, she was really into human factors, and she set up this database where people could put on their errors, and everyone in Wales then could learn from them. It's totally anonymous. It was just a tool where we could share and learn from our errors. How many people do you think submitted an error on the database? Well, the answer is 1, and it was her. It was a really interesting one, though. It was a practice that had a medical emergency, and they couldn't phone an ambulance. They couldn't phone 999, and they kept trying, and they kept trying, but they couldn't get through to the emergency services. And then the receptionist tried and got through straight away. And the error that the dentist was making when they tried to make the call was that you had to dial 9 for an outside line, So when they were putting 3 nines in, of course, the first 9 was to dial the outside line. And that's human factors. But luckily, the patient was okay, and they changed the way the telephone system worked. But it just goes to show that we just do not report and share and learn from our errors. So the question is, if human factors can reduce our complications by 80%, where are we on this diagram of awareness, application, and mastery? Well, the answer is half of us aren't even on the triangle, and the other half are only at the awareness stage. So you can see we've got a long way to go to really implement these human factor principles to improve patient safety. And my challenge to myself really is, how do we do this? How can we do this? How can we get our profession to master human factors? Well, I have the answer, and the answer is quite straightforward really. We need to not just develop barriers, but it's about changing the whole culture and the outlook of our profession. We need to encourage a culture of fairness and a just culture, which fundamentally differentiates between an unintentional one-off action and people who are deliberately deviating from the rules of good practice. And only then will we properly share and learn from our errors, and then we can systematically use human factor tools. But I use the word systematically, and I underline it deliberately there, because human factors isn't about just using checklists when you have time to, or just engaging with these principles when you want to. It's a bit like the seatbelt on your car. When you get into your car, you don't just put your seatbelt on when, you don't just put your seatbelt on when you're in a rush and it's raining. You put your seatbelt on every single time you get in your car. Well, that's how checklists have to be in these human factors interventions. It has to be so important and so ingrained in our culture that we use them systematically. And all of human factors research now talks about that for sure it's the human that makes the error, but that's not the primary cause. That's just a symptom of the problem. The real problem, the root cause, is the organizational and the situational factors that surround it. And so when we start analyzing our errors, it's not adequate just to target each individual or blame an individual, but instead that incident should be seen as a current state of safety of your practice. And you need to address the much wider issues that it affects. But we just don't understand this in dentistry. And so I can give you another example. The picture on the left is a typical side after one of our students has finished an implant placement, which quite frankly is quite dangerous. I mean, if you like to get a needle stick there, it's difficult for the nursing team to tidy away. The picture on the right is how it should look. And so we did some research around having a shadow board where you, on the drape packs, you would actually put the shadows so you can see exactly where everything goes, everything's in its place. A really simple human factors intervention to improve patient safety. And it's fairly obvious and simple, as Robbie said at the start of this, some of these interventions are. But how many people, how many students do you think use this when they had the choice? None. None of them would go down to the end of the corridor to pick up one of these because they just didn't see the need. And the conclusion of Dr. Lind, who led the research in this project, so there was little recognition from the participants of implementing such a system to address the latent conditions that may exist within the working environment. And this is what I get all the time. And until we start to change the culture, we will not be able to improve patient safety by implementing human factors tools. And this is where it got a bit confusing for me and a bit frustrating, because pilots have managed it. You know, pilots aren't super safe. They make the same number of errors that you or I make, but airplanes aren't falling out of the sky, are they? They've managed to get these barriers and engage with them. So what's been so different in aviation compared to in dentistry? And I really wanted to try and understand this, because I've tried for the last 5-10 years to put these barriers into place. I'll just give you some examples this evening, but none of them work. So I started to look into what is different in the aviation industry to dentistry. And it became very clear when I started looking into it what the difference was. The difference was is after that Tenerife accident, they were obliged to share and learn from their errors. And this was critical, and this happened in a very interesting way, because when they first started to share and learn from their errors, all they really shared were things like near misses and inconsequential things that they couldn't really get into trouble for. But what it did do is it did two things. First of all, it helped highlight what some of the errors are, so you can start to design some systems and barriers to prevent those errors from progressing into an airline accident. But the most important thing that it did is it changed the culture, because they started to accept that they do make mistakes and they're not all super macho and they're not infallible. And so it started to change the culture. So they started to engage with these tools, which then made them start to share more of their errors and start sharing more serious errors. And so what happened over the last 30 years in aviation is that sharing and reporting their errors drove learning, which changed the culture of aviation. For sure, it took a long time, and there were lots of expensive mistakes along the way. I mean, if you refuel a 747 incorrectly, you can tip it up and cause millions of pounds worth of damage. So you think if it happened once, it wouldn't happen ever again. It certainly wouldn't happen twice, or 3 times, or 4 times, or 5 times. But they kind of got there in the end. But we're so far away from this in dentistry. Our culture is very much around not sharing our errors, and it's very much around hiding our errors. I can give you lots of examples. This was a maxillofacial surgeon that put an implant into the mandible, and he put it straight into the ID nerve. This particular dentist had no preoperative radiographs. He drilled the osteotomy purely just by clinical examination. As it happens, he went straight into the ID nerve, and the patient had complete anesthesia of her lip. But in his defense, his argument was the implant must have migrated there. He couldn't accept the fact that he would do this to a patient. He was that arrogant. How can I defend that? And obviously he was found liable. This was a really sad case. This dentist was taking out a lower 8 using a chisel, and it's a technique you can use. You can put the chisel on and you can fracture the lingual plate and take the tooth out lingually, but he didn't do it quite correctly, and you can see he dislodged the tooth there. You can see the tooth roots in the angle of the mandible, and the patient had paresthesia of the lip and total anesthesia of the side of her tongue, and she was obviously in a lot of pain. She's 24, this girl. And he said, listen, it's a known complication, it's a known technique, I've done nothing wrong. So this 24-year-old, his life has been radically changed, and he couldn't even understand the errors that he had made. And this is the culture we have a lot of the time in dentistry. We need to change our culture to understand that errors aren't synonymous with negligence, and that we need to share and learn from our errors. We need to move away from this ethos of infallibility, where an individual problem can be remedied with blame and punishment. And we need to look for the root causes and create a culture where we can share and learn from our errors. And even trainers and educators fall foul of this culture. This is an FD trainer. I wrote to all the FD trainers in the area, and I asked them to take part in a study about sharing and learning from errors. And this was a typical response, to be fair. They said, no, we're not going to share and learn from errors, not in this climate. Are you stupid? And this was quite a common response that I got. But the problem with that kind of attitude is that it breeds, particularly in our dentists that are learning, the real professionals don't make mistakes, and then so you don't share them, and then eventually you don't build protective barriers to prevent the error, and then the patient becomes harmed. And this cycle is something that Frank Wenoir put together. And so this is not true just for England, this is true for France and for Europe. And it goes back to my theory in terms of aviation, where reporting drives learning, which drives a safety culture. Other barriers are that we don't want to introduce human factors and reporting because it's more bureaucracy and more red tape. They've identified 5 attitudes that are a danger to patient safety. And there's only one group of people which feature more highly in them than dentists, and that's orthopedic surgeons. But all of these attitudes are very prevalent within dentists, particularly anti-authority. Dentists are renowned, and this is backed up with lots of behavioral science research, for being anti-authority, and they put it down to the fact that we work in our own confined rooms and we have to rely on our own professional judgment, so we become very, very anti-authority. A third of orthopedic surgeons are a danger to their patients, according to the literature. And if you know any orthopedic surgeons, you can probably find it difficult to contest that theory. This was a macho advert for flying back in the 1940s. And that's kind of where we are in dentistry now, isn't it? Of course, in aviation, that's changed an awful lot. But again, I see this all the time in my career. Look at this case here. This dentist has put an implant in, and look how close he's come to causing harm to this patient. But that wasn't why the patient was referred to me. It wasn't even referred to me to remove the upper 6 there with all the fractured files in the canal network. It was referred to me because they put an implant into the sinus. But you can start to get a feeling, can't you, of this dentist's particular attitude towards patient safety. As it happens, I managed to take the implant out, and I did a sinus graft, and the patient was fine, so everybody was happy. But it's so difficult in primary care to change the culture, because we have, as I say, 10,000 practices, all with different operating protocols, different governance, different policies. It's much, much easier in secondary care, and that's why medicine is so much further advanced in human factors than dentistry is. But the real barrier to patient safety is the GDC, which is ironic, isn't it? Because their strapline is protecting patients. And the reason why we don't share and learn from our errors, which is critical for improving a patient safety culture, is because we're scared of being struck off. So in actual fact, the GDC itself is being a barrier to protecting patients. And it's because of this, I wrote to them about 5 or 6 years ago, and I explained this to them. And I expected to be in a heap of trouble about it, but I wasn't. And it was Tom Scott, who was the director of the fitness to practice panels, and the director of strategy, who contacted me back and said, "No, listen, we get this. How can we help?" And I said, "Well, you need to change the way that you work, and we need to change this whole fear culture to a culture around fair blame and acknowledging the fact that we're all going to make errors, and we just start thinking about the working environment that we have." And over the last few years, I've trained every single case examiner in human factors. I've trained and sat down with every single fitness to practice board member and panel member. And I've said to them, look, dentists are going to make errors, and you need to look at the contextual risks rather than just the conduct risks. And they've started to listen to the point where they've actually appointed now a human factors expert within the GDC. And one of the things they've done, which I'm very pleased about, is they have something called the impairment test. And so when it comes to the GDC, what they're looking at, which is different from litigation, when it comes to litigation, you're looking at causation and liability. When you're looking at the GDC, all they're asking is, have you breached the standards? And what they've done is they've introduced this thing called the impairment test. And what they do is they look at the case examiners and they look at these 3 aspects: your level of insight, remediation, and the risk of repetition. So if you can demonstrate you've got a really good insight of what you've done and the error that was made, and you did the best you could do to remedy it, and you can demonstrate that because of human factors interventions, if you like, you can put into place that the risk of repetition is virtually nil, there's no reason at all for the GDC to even raise a sanction against you. And this is the key thing that they've done recently, and hopefully this will go a long way into restoring the confidence that people have in the GDC, because only then will we start sharing and learning from our errors. The other thing that they've done is they've started working much more with people like the CQC and things to look at these situational environments. So, for example, if you're a young associate that's working in an environment where you're forced to do lots of UDAs, you haven't got proper equipment and things, is that your fault or is that the fault of the organisation? And at the moment, because of the statute, the GDC can only reprimand the registrant. So they have to rely on other people like the CQC and things to look at these wider issues, and they're working much better with them now to try and do that. And one of the things that's good is that there's evidence around all of this. So if you look at the Medical Council, if you can show insight into what you've done, only 5% of doctors were erased, whereas if there's no insight, 60% were raised. And the GDC have even started doing research around human factors. So they look at root cause issues around fitness to practice considerations. And you can see the list there. Sure, a quarter of it is around poor treatment, but 3/4 is nothing to do with your technical ability in your treatment. It's all to do with human factors. Poor record keeping, failure to consent, fraud, prescribing issues. All of these things, 75% of these issues, which is quite close to our 80%, isn't it, is all human factors issues. And I've even narrowed it down into risk factors of you being in front of a fitness to practice panel. Number one, work overload, pressure to meet financial targets, poor performance, poor communication. All these are human factors issues. And so if that isn't evidence enough that human factors is critical in patient safety, I don't know what is. And in fact, it's not just dentists, it's nurses are the same, technicians, and indeed hygienists. The other thing they have to do is they have to ensure public confidence in the profession. So they've also done some research around what the public think of the different errors that we make. So they asked the question, if a dentist accidentally prescribes antibiotic that gives them a reaction which leads them to be in hospital, what percentage of them do you think said that dentist should be suspended or struck off? Well, 63% said if we wrote a prescription that ended up with a patient being in hospital, 63% of the population, this is a big study, thousands of people, 63% thinks it should be struck off. And the nurse doesn't get away with it either. The nurse should be struck off as well. It's not quite as extreme. What about if we took the wrong tooth out? So, you know, I've been a dentist now for over 20 years. I've really committed myself to the profession. I've worked hard to get where I am. I take one tooth out that's wrong tooth extraction, and almost half the population think I should be struck off or suspended. And this is the face of public perception around the errors that we make. Interesting, we're doing some research around root cause factors around why dentists and nurses end up in fitness to practice panels. And nurses are much easier to analyze than dentists actually. But I can just give you a list of why last year nurses were erased from the register. Falsely claiming benefits. One was pretending to be a man. I had to look this one up just to make sure it was true. And here's the committee notes. Theft, submitting false observations. That was a nurse that was observing and she didn't bother turning up, so she just submitted false observations. One nurse was ordering antibiotics and selling on the black market, indecent photographs, speeding, supplying drugs, assault. Now, all of these are human factors. This is nothing to do with technical ability or knowledge, is it? And then finally, tooth whitening beyond the scope of practice and hygiene. And when you look at the hygiene one, even this is human factors. Reusing matrix bands. We all know why you shouldn't reuse matrix bands. Reusing gloves, reusing aspirator tips. What is it about the system that nurse worked in which allowed her to make these errors? They're the questions that we should be asking. And even if we can get around all of this and we do start sharing and reporting our errors, we don't even know what to report or who to report. So we can't start to change our culture. In fact, I don't even like the word report. That makes it sound like we're in trouble, doesn't it? We should be record. And should we be recording things like this. This obviously is the wrong implant site. Or this, the implant's placed too buccal. Should we be recording this and sharing this? This was referred for implant in the upper central incisor. I sent it back to the dentist because there was a lesion on the central, and the dentist did this, and then obviously the gutta percha has extruded into the buccal sulcus. I mean, the dentist did this. It's lovely. They really are. They can't do more for their patients. What is it on that day that caused her to make this error? Should we be reporting or recording this? Well, we don't know is the answer. We know why dentists need defending, and that's the proportion of claims from the DDU that I work with. I know the most common reasons why people get into trouble for implants: failure to offer implants as an alternative, failure to explain the options and consent, poorly planned position, peri-implantitis, but part of a lack of a coordinated aftercare. So again, all of these are human factors. And we did a study, a proposed study, a pilot study, looking at what errors people make in practice. And we had 15 practices, and these are the things that they reported. And this is hugely useful to us because we can start to build in barriers to stop these happening. In fact, we went on further and we took this research a bit further on, and Dr. Rosie Moss has had a look at developing a recording and learning platform tool. And she found that most of the errors we make are in clinical treatment. That's fine. Most of them didn't cause any degree of harm, although some did. But when she looked at the root causes, look, time pressures, failure of equipment, lack of organization, adequate communication, these are the things we start to need to concentrate on to make sure we reduce our complications rate and improve patient safety. In fact, she concluded that, yeah, mishaps are high in frequency, but in actual fact, the amount of harm they cause are very, very low, which is great in actual fact. That's why we're still on the register. But, you know, don't forget this: one of those days, one of those incidents is going to harm or kill a patient, and we don't want it to be you. So why do we make errors? Well, I see them all the time. I've given you lots and lots of examples. And there's a load of reasons why I make errors, and I want to differentiate between fault and between error. So a fault is a deliberate divergence from a given system, and I don't really want to deal with that because, you know, that's all down to personality types. I'm much more interested in errors. So this is an inadvertent divergence. This is what happens to us. This is that 2 to 4 a day. And we make errors for a number of reasons. The first thing we do is we underestimate the risk of complications when we're treatment planning. So you might see that curved canal, and when you're treatment planning, you think to yourself, you know what, I'll be able to do that. And then when it comes to the actual procedure, you think to yourself, oh my God, did I really treatment plan this? This canal is really curved. You've probably all been there. The other thing we do is we adopt an empathic approach. We care. We don't want to just do root canal. We want to save that tooth. We want to save that person's smile. And, you know, I can give you an example. I was in last year. This was a patient that was going to university, and she needed to have implants to replace her missing lateral incisors. And she needed to have 6 millimeters of space there for me to put an implant in safely. But she had 5.6 millimeters. And she was desperate to go to university with her implants and the braces off, and she had no more money left. And so the question to you is, what do I do? Do I just go ahead and put the implants in? It'll probably be okay. Or do I put her through another 6 months of ortho and she has to go to university with dentures and braces and things? What do I do? Well, the answer is simple. Making compromises to avoid displeasing somebody or to please someone quickly relies on you surrendering your certain principles, which ultimately leads to more errors and complications. The other thing is, the other reason why we make errors is that 80% of dentists think they're smarter or more skillful than all other dentists. And so you get something called superiority bias, and this gives you a feeling of superiority. But by far the most common reason, and all of our research and all the literature really backs this up, is that it's all down to stress, fatigue, and time constraints. I'm not going to really talk about this for too much because I know that I've gone on for long enough. But there's a couple of things I wanted to highlight. The first thing is that you need to realize that stress is accumulative and your brain is finite. So if you come to work stressed and then you have another stress, it all builds up. So you need to learn how to manage your stress. And this is quite a key phrase in human factors. And then when it comes to time, this is probably the most important thing in human factors in dentistry. And there's this whole principle called efficiency versus thoroughness trade-off. So you could be the safest dentist in the world and see one patient a day, or you could be the richest dentist in the world but the most unsafe and see 100 people a day. And it's where do you draw that line and how do you gauge that line? I can just give you an example. I got this patient was having upper implants and a lower chrome, and you can see there that the clasp is fractured. And I can tell you what's happened. He was just polishing it off to send it back to me, and the clasp got caught in the fluffy wheel, which broke it off. And rather than him erring on the side of thoroughness, he just tried to fix it in the acrylic. And that's actually quite dangerous because that could have come off, the patient could have swallowed it. In the worst case scenario, it could have got impaled into their stomach or their intestine or something. And so this technician was very much erring on the side of efficiency rather than thoroughness. But it's where do you draw that line? And if you're starting to use phrases in your head like, that looks okay, it's fine as it is, then it probably is most of the time, but you're probably erring on the side of efficiency rather than thoroughness. And it's everywhere we go. I gave a similar lecture to this in the BDA, and here's the lecture theatre. And if you look at the door on the right there, it says fire exit. You can see they put a new cable in the lecture theatre to the projector. And I was standing on the podium and I was thinking to myself, I wonder how thorough these electricians were, or were they erring on the side of efficiency? And you can see why I had to go outside the room. So you can guess how they managed that, can't you? Well, I took a picture. And that's in the lecture theatre at the BDA. So you can probably answer the question that they're erring on the side of efficiency rather than thoroughness. But the key thing for us to realize, and this is really the whole theme of this lecture, is that we are the weakest link. It's because of us. And until we start to address the way we approach complications from a systems approach, we won't improve things. And I just want to spend the last 5 or 10 minutes just giving you some human factor tools which you could introduce into your practice to improve patient safety. And the most obvious one is the lock tips. And if you don't have a copy of these, please do speak to Robbie or speak to me, and I'll make sure you have a copy. The next thing is threat and error management. And so what you're encouraged to do is look around your practice and say, well, what could potentially be an issue here? And the most obvious one is latex gloves, because you're not going to wear latex gloves to a latex allergic patient when you're not in a rush, you've got all the time in the world, you've read the notes thoroughly. You're going to do it when you're behind and you're in a rush. One way to manage that is just to have no latex gloves in the practice, and you can't make that error. And if you do that for most of the things in your surgery, you can start to rule out the things that are potentially going to cause problems. And you can start to see on the internet some threat and error management, which are disasters kind of waiting to happen. Obviously communication, and that's a key issue, which is a whole separate subject. Make risks obvious, again, that's fairly obvious, human factors, and most softwares do that anyway. Another tool, a very powerful human factor tool, is called What If, and we teach this to our implantology students. If you've got a patient in, I don't know, they're taking an anticoagulant, for example, and if you just sit there and think to yourself, well, what would I do actually if this patient started to bleed? How would I manage that? And you say, well, I'll get a pack, I might give them some local adrenaline in, I might get my nurse to go and get some Surgicel. The fact that you sat there and thought about all of that before the procedure started means that if it does happen in the procedure, you're much more vigilant. You're not stressed, and you can deal with it in a much better way. And we use this a lot before they start placing implants, but we use it a lot in our practice as well. It frees up your mental resources, which, as I say, is finite. Checklists, I don't need to tell you the importance of checklists. And there's lots and lots of research. If they're used properly, and they have to be used properly within this safety culture concept, then they will really reduce fatalities and morbidities. And this is just the WHO Safe Surgery Checklist, which increased patient safety by 1/3. And that's the version that we did and published in the BDJ. Again, if you want a copy of this Safe Surgery Checklist, then please get in touch with me, and you're very welcome to have a copy of it. Team briefings before complex procedures takes a minute, and again has been shown to radically reduce errors. Reducing the authority gradient. One of the key criticisms in the airline disaster at the very start of this presentation is, why didn't the co-pilot stop the pilot from taking off when they didn't have permission? And the answer was because that wasn't the culture. And certainly in our practice, we've reduced the authority gradients, so all the nurses, even the cleaners, if they see something unsafe, they're encouraged to speak up. Keep it simple for 2 reasons. First of all, if it's simple, it's easier and less likely to have complications. But it's much more complicated than that. If it's simple, you're less stressed, you're more vigilant, and therefore you do a better job. You can access your higher brain centers much better when you're less stressed. It can go too simple. This was a patient that bought a denture off the internet. So it's like a denture off the internet. And this is what it was. And she loved it. She now has implants, luckily. But a lot of the work that I do involves investigating the ways that we can reduce the complexity of treatment, because the more simple it is, the less errors you're going to make. And of course, one way you can do that is by standardization. Using digital aids also increases patient safety, where you can interact much better with the patient. Technology is moving along. But by far the most important tool, with all of these things, is that we start to share and learn from our errors. So whether you're in peer review groups, whether in your practice, even if it's just with your nurse, if you can start to share and learn from your errors, you'll start to change the culture of dentistry. And if you do that, we'll start to reduce these near misses, and we'll start to change the environment where we work to improve patient safety. And I'm really glad that Robbie's asked me to talk to you at this point, because now is a time we can do this, isn't it? We're all starting to look at the way we practice, and we're starting to look at the organizational factors and the situational factors that affect the way that we work. And if you can bear in mind these risk factors that are risk factors for fitness to practice hearings, you can start to change the way that we work. We've certainly started to change the way we work. This was our practice last week, and I'm sure your practices look very similar. I get sent lots and lots of pictures like this. You can see the image on the left there, which is an implant very close to the ID nerve. And this dentist said to me, "Aren't I fantastic? Aren't I the best dentist in the world, because I can put an implant in this close to the nerve and the patient's fine?" And I emailed him back and I said, "No, I think you're an absolute idiot. I can't understand why you would put the patient at that risk." I used the example of when I got on an aeroplane, I want the pilot to take off as uneventfully as possible, fly the aeroplane, and land as safely as possible. I don't care if he can loop to loop in a helicopter. I just want a totally uneventful flight. And that's what our patients want from us. And this is a phrase by Frank Renoir, and it's one that I live my practice in life by. The very best dental care professionals are those who exercise their informed judgment so precisely they don't find themselves in situations where they have to call on their remarkable skills and talents. And that's where we want you to be. So to conclude, 80% of our complications are due to human error, but so are 100% of our successes. They're down to us as part of an engaged profession. But I really passionately believe if we're going to improve patient safety, we really, really need to start sharing and learning from the errors that we make. And we can only do that by creating a just patient safety culture. Thank you very much for your time.
That was great. Thanks, Simon.
I'm sorry I went on a bit.
No, you didn't at all. No, it's pretty much bang on time. Can you end your screen share just so we can ping everyone up, because people can show themselves?
Yeah, I'll stop share.
Great.
I've got to take the dog out in a minute. Have you seen the weather outside?
Yeah, the monsoon's just arrived on the world, isn't it, I think? That was superb, thank you. We've got a couple of questions to start with. One thing I'll just say before I forget, I've put a link to the oral surgery LockSip toolkit in the chat, so people can just click that and it brings up the PDF, and that explains exactly what a LockSip is if nobody knows, and it's got that document on that you talked about, so it's quite handy for anyone, especially practice owners. First questions are from Nick Longridge. The first one says, do you discuss the risk of human factors with patients before surgery? And because even with the best systematic processes, obviously errors can still occur, and is it part of your consent process?
I don't think you specifically title it as human factors. I think human factors is more embedded in a culture, and we have the same in teaching. In fact, some of the hospitals, they teach human factors as a module, like they say, you must do checklists, you must do team briefings, you must decrease the authority gradient. But in actual fact, that's rubbish. What you want to do is just have a culture where you use checklists, where you do team briefings beforehand. And so it's much more of a sort of soft science, which is there, but not necessarily that you discuss.
Second part of the question is totally separate, but is a separated instrument in a canal a never event? Just because Nick had somebody asking recently.
No,
I didn't think it was either.
No.
I've got a couple of things I wanted to sort of ask you or talk about. So, advice from your experience of your own practices and working in the hospital and that kind of stuff on getting your team members, and it's not even just nurses, it's hygienists, therapists, associates, to implement a checklist and to see the value in it. I've worked in 2 hospitals, one that used whose sheets before extractions for every single one, really systematically, had briefings at the start of surgery, all that kind of stuff in the local anaesthetic outpatient setting. And then I worked in another one when they didn't do any of that. And when I tried to introduce it, they were all up for it and it sounded great, but then the reality was nobody bothered. And it became, exactly as you said, after the procedure had been done, it was something that was filled out at that stage and just ticked boxes.
Yeah. Well, you're right. And I went into a hospital not too long ago, and they were meant to be demonstrated to me how fantastic their protocols were for human factors. And one of their protocols was they wrote the tooth on the whiteboard, and then they had checklists and everything else. And the dentist wrote the tooth on the whiteboard and moved on. And I said, hang on, you've written the upper left 5 there, and it's the upper right 5. And he just walked to the whiteboard, rubbed it out, and then wrote upper right 5. And I said, whoa, hang on. That's quite a significant thing you've done there. And he didn't even understand the relevance of him writing the wrong tooth. And you're right, it's a real issue in that unless you use these tools as part of this culture, then they can be more harm than they can do good. And from my experience, the only way that I've managed to do it successfully is really in my own clinic with me, and that's by really engaging the nurses and giving them ownership of it. And if you get some really, particularly if you choose a kind of fairly bossy nurse, and we've got a couple in our practice, they don't even let me start work until it's done. And that's what you want. You want that sort of practice team where they have ownership of it, and I think that's the only really way that you can do it, is by engaging the team fully and giving them responsibility for it.
Yeah, And actually, in the hospital where we did the briefings before starting, so at the start of the morning list, we'd sit and go through all the patients and talk about what procedures are going to be and any nuances that were relevant to the medical history or a certain bit of kit that I might want. The nurses loved it because they felt really involved and really engaged, and they had in their own head what they needed to do to be organised. And like you say, if they're involved in it and they understand the value, they actually benefit from it.
Yeah, absolutely. I noticed on the chat that Nick's put on there that with a file being a foreign object that's retained, then it's a grey area. I don't think it is, because you could argue, couldn't you, that a crown is a foreign object that's retained, or a filling is a foreign object that's retained. I really don't think it is, but I know Mick Horton very well, who's on the Never Events committee.
I suppose the patient consented to have the crown left in the mouth, whereas they didn't consent, or maybe they did. It's got to be in your consent. Yeah.
So I'll clarify that, Nick, and I'll get back to you. But I don't think it is a Never Event. And I know John Milne as well, and he's in the Never Events committee, and I'll ask him.
What else was I going to say? I think that you put a couple of points that you picked up on that I thought was good to discuss further because they're really important. One was the authority hierarchy, because I think particularly in potentially single-handed practices or small practices where a dentist or a principal perhaps has been quite a dominant character, I think that'd be a real big hurdle to overcome with some nurses.
Yeah, definitely.
Nurses have really never spoken up to the dentist and never said anything. I think that's got to change, hasn't it?
Yeah, and that is well recognised. And in fact, there's a very famous case of Michael Bromley where his wife went in for ENT surgery just to have polyps removed, and there was complications with the anaesthetic.
Yeah.
And the nurse was there with the tracheotomy needle, and she wasn't allowed, in her mind, to say just use the trachea needle. And if she was unable to speak up, his wife would be alive today.
Yeah.
And that, of course, led him to start this whole human factors clinical group that he leads now for medicine.
Yeah. And then, the other thing, this is just to share a story from my own experience in the hospital, and it's not to pat myself on the back, although I will gladly do it because it went really well. But we had a patient who was referred into Arrow Park with a local anaesthetic allergy, which we've all heard patients say they're allergic and this, that and the other, and you normally brush it off, and a lot of them do end up with us at Arrow, or in a max factor, oral surgery unit to get the treatment. And there's just something about the history with this one that sounded like it could actually be legitimate, and she was treated in a practice, and I don't know, it might be one of you guys here that treated her, because I can't remember what practice it was. Given local anaesthetic, it was Articaine. She previously had lidocaine loads of times with no problem, but had Articaine on this one occasion, and then after five minutes or so, started to develop a feeling of tightness in her throat, feeling of difficulty breathing. And then an ambulance was called and an EpiPen was given and all that kind of stuff. So the hospital did say that they thought it was anaphylaxis, and they deemed that it probably was the local because they hadn't given any other treatment at that point. So the patient was referred in. She was she's quite an anxious patient, and she was very, very aware of her anxiety, and she wondered whether it was an anxiety attack herself. She's a nurse, so she was really switched on. She wasn't one of these sort of loopy patients. Really lovely lady. And we discussed at the clinic what we were going to do for treatment. Should we get tested first? Should we try a different anaesthetic type? Anyhow, so we gave her lidocaine instead of Articaine because she'd had that in the past fine. And that's what we decided we were going to do. And she was comfortable with that, but that we were doing it in a hospital setting where we've got the backup and all that kind of stuff. So anyway, the day of surgery comes, but before the patient came in, I had a nurse and a CSW with me. And I said, look, nothing is going to happen. This is going to be fine, but just in case, if she has an anaphylaxis, what will we do? And we literally got the emergency drugs trolley and the corridor, which normally lives in a totally separate part of the outpatients. We had the anaphylaxis box out. We looked at what was inside it. We talked about who would do what role. We talked about calling the people in the department. we went through the whole thing. It took 2 minutes, literally 2 minutes to do. And sure enough, after giving the locals, she started going into anaphylaxis. She started losing her airway. She started getting tight, shortness of breath. And we did exactly what we just talked about 2 minutes ago. And even despite that, in an experienced registered general nurse of like 20 odd years, in drawing up the adrenaline into the syringe, snapped the bottle and dropped it, and dropped the adrenaline everywhere, even though we'd rehearsed it. Now, luckily, there were 2 ampules, so it was fine. But even with the practice and having it there and having everything ready, mistakes do still happen. So imagine the stress if all that was in a totally different room, if we hadn't looked through it beforehand. It went beautifully well, and the patient was absolutely fine. And it was the model medical emergency. It's like you're doing it in a practice room, but it was for real. And it was pure luck, really, but it was being organised. So, like you said, thinking things through, thinking what can go wrong before it goes wrong, particularly if you've got that patient who's got that one little thing. Because on a busy day, you ignore that fact, you think, oh, it'll never happen. But if you prepare for the fact that it can, on that day made such a difference.
Yeah. What if? It frees up your mental resources as well, so you're less stressed and you're more vigilant when you.
Yeah, and I've never given intramuscular adrenaline before, but on the day it felt very relaxed, almost not quite relaxed clearly, but it was so much less stressful than me thinking, Christ, what do I do for anaphylaxis again? What do we give? How much adrenaline? Where is the adrenaline? Do you open the room to tell someone to call 2222? It was like a rehearsal. It was great, and it was so much calmer. And the patient was calm in the room. There wasn't people running in and out. It was good.
Well done.
Well, it's just interesting. You can apply that to anything, can't you? Anything in your practice,
Absolutely.
And then the sharing errors thing, what's your plan for that then? What do you think going forwards?
Well, I'm having a slight issue with this because I talked to Sarah Hurley about this at length, and they've got this new system, this Dipson system, which they think is going to work for the whole of medicine, for the whole of dentistry as a reporting system. And they want one system for medicine nationally. And I say to her that I don't think it's going to work because I think it's got a few issues. One of them is not anonymous, and all the research we've done and all the evidence is if it's not anonymous, you're not going to report real events. You might report things like, oh, I put the wrong crown on a tooth or something like this, or I put the wrong shade composite in or something like this, things you can't get really into trouble for, but you're not going to share real errors that would improve patient safety. And that's been borne out in Scotland, because in Scotland, they have to report, do a certain number of significant event analysis as part of their CPD. And they do, but it's all things like that. It's all things like the wrong shade and this type of stuff. And so there is a national system coming online, and you can get involved with it. You can email Lucille, I think her name is, and you can contribute to it. But I don't think it's going to work very well for dentistry, because first of all, dentistry is different to medicine because we don't tend to kill people. And secondly, all the fundamental principles that we've identified and Rosie's identified in her projects is around things like anonymity and being quick and easy to use and all this type of stuff. And so I am developing a reporting software, which is almost finished now, that will feed into that. So if you want more information on that, then, and you want to use it in your practices, please feel free to contact me.
Great. I'll be sending around an email link for feedback through SurveyMonkey, but this is the QR code, so some people do it straight away on their phones. But thanks again, Sarah, that was superb. That's great.
No, my pleasure. As I say, my email address is on the last slide. If you want to contact me about anything to do with human factors or any of the resources that we have available, then please don't hesitate to drop me an email.
And for everyone else, thanks so much for sticking around for these the last few weeks. I hope they've been helpful. Feedback's been really, really good, and most people seem to think it was a good idea.
Yeah, definitely. Thank you so much, Robbie.
With everyone starting back up in practice, I think we'll leave it for a little bit now because everyone's going to have enough going on. But maybe in a couple of months' time we can try and pick it back up. I've been collecting suggestions on topics people want, so let me know if there's anything anyone wants.
Fabulous.
But yeah, good luck everybody whenever you get back, whenever that is.
Yeah, thank you so much, Robbie.
No worries, thanks guys. Take care.